I am probably hyperactive, those of you who know me. So I cannot stand behind the podium. It just will not work for me. Now, I'm going to talk about, they asked me to talk about lines, locks, and access, all right? So this is something that's a mixed bag for us pediatric GI docs. Some of us do pegs. Some of us don't do pegs. Some of us will change our buttons. Some don't. None of us, I think, put central lines in, but some of us take care of them or help take care of them, some more than others. And so this is going to be a mixture. And some of you are like, oh, I don't do any of this. And some of you are like, I do all this. And so it's going to be a mixture. I'm going to give you, and some of this, there's absolutely no data. Absolutely, like everything in nutrition, there's absolutely no data. All right, central lines. All right. Well, you've already heard from this from our previous speaker about peripheral. We use a lot of PICC lines, and that's a great thing. I think that's good for the patients. It's a stable access. Peripheral lines, again, depends on the guideline. If you have higher osmolarity, of course, you increase your risk of complications. And so the guidelines say, depending on the guideline you look at, somewhere between 900 to 1,200 milliosmoles. You get too high, you have more inflammation or infiltration, more phlebitis. Of course, it does limit your nutrition that you can give by a peripheral line. Of course, for infants, probably a term infant, you can probably get to about a max of 10%. Preterm, about 12.5% before you start to hit your milliosmoles. Of course, central lines, there's a variety of those as well. You can get central lines that are temporary for short-term use. A lot of ICU patients will have a temporary central line. When you start to talk about permanent lines, these are designed for home use. They're tunneled to prevent infections. They're more stable. They're a little longer. You can put what they call a loop in it, a tension loop, and that's the idea is the kid jerks it. You pull that loop out, and hopefully you save your line. Of course, that still won't save you if the kid's sitting in the lap of the grandmother and the mom comes to pick the kid up and the line somehow under the edge of the rocking chair, and they jerk it out. I mean, that's happened. So the tip, as you've heard already, needs to be central, usually superior vena cava, or the junction with the right atrium. Again, you don't put it in the right atrium, but some folks like to say right at the tip there because that gives you, again, some distance that if you do have something, you aren't going to hopefully pull it all the way out. Permanent central lines, again, there's all sorts of varieties of these. Tunneled is the one that the majority of people use. That's what you see most of the time. There are lumens, there are ports. Again, lots of ports used in chemotherapy patients, and you can access those. A lot of worry with those with the infiltration risk. So people worry about that, although I do see it done. We've seen it done, and we've also seen the things that can happen with it. Risk of infection, this is a number that you've seen already once. There's this, the same study is cited 1.5 infections per year for every central line. Now, this is an important point, is the substance that the central line is made of makes a huge difference. There's a difference, all right? Usually we heparin lock these to prevent thrombosis, right? Blood system, clots, thrombosis is bad if that's your lifeline, if you need it for your parenteral nutrition. But there's now some good studies that show that if you have repeated infections, you might want to think about an ethanol lock. I don't know, Rob, if you saw this meta-analysis, this was just published that has come out, looking at ethanol lock use in pediatric intestinal failure patients. And the data from this meta-analysis is very strongly supportive in this group, in pediatric intestinal failure patients, which probably have a higher risk of translocation of using ethanol locks to prevent their central line infections. But the trouble with the ethanol lock is it causes breakdown of some of the other line materials, and so your central line to do ethanol lock needs to be a silicone-based line. All right, so if you have an intestinal failure patient, you may want to talk to your surgeons and say, we need to think about the substance our line is made of. Polling question. All right, we're going to try this. An infant with inadequate intake is to be started on nasogastric feedings. The accurate method to verify placement is... I know, the internet's a little slow here. What I think is cool is watching this change as the numbers come in. All right. And how many should we actually expect? Where's Yeah, I know. We should expect much more than 16. Aha. Total results 2, though. There we go, 5. Auscultation. It's going down. It's going up. That's a good question. While we're waiting for the poll to come through, actually, most of them are made of silicone. There are some made of polypropylene, though. Okay, and that's the other big type of line that is used. But again, those are actually the ones that they've actually shown that when they're exposed to alcohol will get brittle and crack. No, you have to do an ethanol dwell. You have to do the ethanol dwell. It has to be. You have to basically. Yeah, that's right. They're incompatible with each other. You're right. Yeah, or just use the ethanol. That's what most people recommend is just ethanol. All right. So the reason I put this poll question in here is because this is what most people see people do at their institution. The question is accurate method. This is their most accurate method. All right. Now we do these NG tubes all the time. We place them. You know, our nursing folks are taught to check them. They auscultate. They'll send the bubble air in. Aspiration, they'll look and pull back and check the pH. Their capnography, where they'll look for CO2 in it, and that's basically if you get CO2, then you're probably in the lungs. Well, guess what? The chest of an infant is like a resonance cavity, just like a guitar, just like a violin. And Marcia Ellett, actually, who was at Indiana, where I moved from to go to Memphis, has done studies that show that basically you can do auscultation and it can sound like it's in the stomach when it's actually in the chest. So the only accurate method is actually a chest x-ray. There are others that have been looked at. They are accurate biochemical, like checking a bilirubin or some enzymes like pepsin, which is from the stomach. You aspirate back, it's in the soft. But the trouble is, you send this to the lab and you have to wait a day for it to come back from your laboratory. So you're waiting a whole day before you start feeds. So it's delayed by laboratory. So the only verified, and again, verified, I underline that, method to confirm placement is a chest x-ray. It's the only verified method. Of course, we worry about radiation in kids. That's a worry. This recommendation isn't flippant from the folks that look at it. But basically, that's the only verified method that we have for placement. You understand what I'm saying? The semantics here is literally, that's the only way we know for sure. There's also similar literature on looking at gastric versus small bowel placement for your line. NG surveillance, it's interesting. There's a little literature here. I'm looking at this. You mark your insertion point. Mark right at the nose where it goes in. If it stays in that same place and it was in before, the studies would tell you it's probably still in. If it moves, though, then you got a problem. It may not be where you put it or where it was placed. Enteric surveillance, again, this is nasogastric, this is nasoenteric, same as above. Mark the insertion point. If it's in the stomach, of course, one of the things, this is one of the few times when they actually have some literature that maybe a residual is helpful. And I'm not even going to start, not even going to go on residuals. I hate residuals. It actually just means you stop feedings. That's all residuals mean. They actually don't have anything to do with feeding tolerance. This is the one place where there's a study that says a residual is helpful. It's a nasal enteric tube where you shouldn't see any residual, really. If you see a residual, then that means the tube's in the stomach. So one study I've seen where a residual is actually helpful. And it was not even gastric placement. So, anyway. All right, so an enteral access case. They told us to put cases in here, so I actually came up with a case for you guys. All right, so JC, I made this name up. This is androgynous, so you can, all right. JC's a 6-month-old referred to GI clinic for poor weight gain. She doesn't spit up or have diarrhea. They state she seems satisfied with just a few ounces at feeding and then refuses further intake. What kind of workup you want to do? What kind of things you think about in a kid with this? All right. So we all see kids like this. You work them up, you look at all sorts of studies, and everybody has a few kids like this. The workup's completely normal. They just seem to have some sort of I guess I call it a programming issue. They just don't seem to have an appetite drive. We see kids like this, and everybody has one or two in their practice. All right, an NG tube is placed, and she's given increased calories, and she gains weight. Any further workup? This is what I call, we do have one person in here actually who did a fellowship in Indiana with me. And Kevin here, he's heard this before. He's heard me say, this is what I call a nutrition challenge. This is a calorie challenge. You have a kid who's failing to thrive. You do lots of tests, but sometimes one of the best tests you can do is actually challenge them with calories. Give them increased calories and they gain weight. What's that tell you? Well, it tells you they don't have an increased metabolic rate. It tells you they don't have an increased usage. It's just a matter of the calories. And that's actually an extremely valuable piece of information. So we gave her a calorie challenge. All right, does she need any further workup? Maybe. She may need some neurologic. She may need to see a neurologist. But on the other hand, if she's not having diarrhea, she's not having spitting up, and she's gaining weight with the calories from a GI standpoint, boy, what are you going to do? What are you going to look for? Because you've shown that she doesn't have any symptoms, and she gains weight with the calories. So some of this is one of those cases where it's, where would you go? What would you look for? At clinic a month later, her weight gain is great, but the oral intake is still inadequate. What's her next step? Well, so supplemental feedings. In most kids, the first choice is an NG tube, all right? And you teach the parents how to place this. Anatomy, of course, is designed to swallow for most kids. When you put something in our mouth, most of the times we swallow it. That's helpful to know. It's a little comforting. All right, a little worrisome, and you can't always get a chest x-ray. This is just, again, reality. This is hardcore, down on the street. This is the truth. Securing the tube is absolutely crucial, all right? Absolutely crucial. And our nurses are very good at this. They teach the parents how to do this. Some of the families, if you don't do a good job securing it, then they'll complain about how it's always out. It's always out. It's always out. Once in, you leave it in. Most of the time, you can leave it in for about a month or so. And here's your NG tube. Very soft, very small, not like the NG tubes we use for suction. And once it's in, most of the time, the kids don't even notice it's there after a while. They learn pretty well just to leave it alone. Do you need it up for GI when you start thinking about a tube? Do you need to check the anatomy? Well, not much literature again. Usually it's part of the workup for the disease process. And sometimes I always tell parents, well, we like to make sure the plumbing's okay at least once. If you have a normal upper GI and the anatomy's in a normal place, do you need to do it again unless something changes? Do you need a gastric emptying study? Again, if you have a history that gives you that, if you see vomiting. Sometimes when kids with poor emptying will eat poorly and they don't have that much spitting up, so sometimes you need to think about it. Sometimes it's a part of a appropriate workup. What about a pH probe study? Now, you guys are pediatric gastroenterologists like I am, right? You guys know that reflux is blamed for juvenile delinquency, hyperactivity, teen pregnancy. Reflux is blamed for everything, all right? I'm getting all these referrals now for dental etching. How many of you have seen a referral for dental etching? All right, I know. All right. So we're doing a lot of pH probes, but do we need one? Well, maybe. If you have some suspicions, you might think about it. But again, we're doing a lot of normals. Again, some of this, we just need more literature. Somebody needs to do some studies. Hopefully somebody can get some funding and do that. Persistent dysphagia. On occasion, we'll see these kids and they have trouble swallowing, poor intake. Basically, the literature says an NG is for short-term use. The literature there's actually studies in this that if it's over 4 weeks, you need to start thinking about a permanent device. All right. The problem, of course, with our neonates is that they have developmental opportunity. They have a developmental improvement. So you see a kid who has dysphagia or aspiration, how long do you wait? And again, how severely are they affected? How bad is their aspiration? Your speech pathologist will give you some quantification of that. They'll tell you, they're fine with ends, nicter. So this is one of those things. This is why, that whole thing about, good judgment and experience comes from bad judgment. You learn by doing this. But you have to think about it. Start thinking about it if it's over 4 weeks. If the nutrition is successful, you've got them challenged, you try to wean them off and it's unsuccessful. You try to wean it down over time and their intake still stays low. Every once in a while you see kids, you get them nutrition better, they eat better, you get their weight up, and they'll take off. But it doesn't always happen. So they have an inadequate nutrition without it. You start to see problems with your NG. This is the thing that drives you towards thinking about a more permanent device. Otitis, sinusitis, repeated placements. That's when you start to think, maybe we've got to think about a permanent device. I will tell you one of my personal things I've learned over the years. When I was young and idealistic, I'd think, we could make some progress. We'll get, Now I've learned right at the beginning, I start mentioning permanent gastrostomy. Start thinking about it. Starting planting the seeds, and the families are a lot more receptive when you actually get there and you probably need it. Just take advantage from my experience. Start mentioning it right off the bat in case they need it. That way it's not going to be out of the blue or a shock to them. Polling question. Loading poll. A percutaneous endoscopically placed gastrostomy tube should be considered when? Nobody's polling? Yeah. Yeah. Good questions. Do you think about periactin? Yes, you sometimes do think about periactin. Milk protein allergy, sometimes you think about that, but usually there's some subtle things that go with that. Again, it's one of those, sometimes it's a judgment call on the kid and the development. All right, so looking at this, basically, when you got significant reflux, obviously you're probably not going to think about a PEG. Short term, hopefully it's NG. When there's delayed emptying, you're going to have an issue with a feeding tube because you're going to have intolerance. So, again, notice now you're voting while I'm just... Oh, man. Man, I'm trying to recruit in... I was going to say, I'm trying to... Okay, it's slow. All right, okay, all right. I was going to say, I'm trying to recruit in Memphis, and those of you who are slow, I want to know who they are because I don't want them on my... All right. Gastrostomy. Thinking about a permanent gastrostomy, a permanent feeding device. Open versus PEG, percutaneous endoscopically placed gastrostomy. How many of you have done a PEG or do PEGs? Good. All right, great. You do an open one with other procedures. Fundoplication, pyloromyotomy. The PEG, however, is a lot quicker, a lot faster recovery than an open procedure. I'm just a quick overview here. The scopes used to pick the site. Hollow needles pushed into the stomach. Guide wire goes in. You grasp with a snare. You use the endoscope to pull the guide wire out of the mouth. Then you use the introducer, attach, pull it through the mouth, down the esophagus, in the stomach. The scope follows it down and visualizes the placement in the stomach. Sounds pretty simple. Sounds pretty straightforward. Of course, the old-fashioned gastrostomies that were placed, the old-fashioned PEGs were actually tubes. All right. And the families were never that enamored of these. All right. So now they have the one steps, and actually they have primary placement gastrostomies. So, and the families like these. Of course, this is a beautiful looking one. Most of the primary placements, you leave a little bit of some extra room here and put some of the washers, spacers. I call them washers because the families know what a washer is. But they put spacers under it, and it looks a little bit like a Christmas tree. Okay. But you do that to give some growth room until it matures. Button replacement. How many of you replace buttons? All right. Not quite as many. All right. Inside the button is a flap. It's a valve, and that's an anti-reflux valve. And that's designed to keep things from flowing back through the gastrostomy. The trouble is that flap is pushed down by the adapter that goes in when you put the feeding tube in. And anything you go back and forth, back and forth, back and forth, eventually will break off. The other thing that sometimes happens, too, is they'll get a little clump of formula down there, and it'll basically be held open and it'll reflux back. So the other thing that happens is, hopefully, if you've got a gastrostomy, you grow, right? And you're going to need a bigger one. Now, the hope is you can just take it out, but not always. Sometimes you have to go to a bigger gastrostomy size. The obturator is needed for a rigid dome tip type gastrostomy. The balloon tip, of course, we like these eventually because the parents themselves can place this. They can replace it. They can change it out themselves. But most people, nobody recommends this for primary placement. If the balloon pops and it comes out and it's not mature yet, and you don't have a mature tract, you have the opportunity for it to separate the stomach from the abdominal wall, and peritonitis is bad. We all agree on that. So they're all primary placements. They're all rigid dome tips, but those are the ones that usually require a doctor to change them. All right. So here's your dome type button. That's what they look like. Most of you have seen these. And then the balloon type. And there again, there's a variety of these. There's a variety of these as well. The connections. These just basically go inside the button in the entry port, and they work basically by friction to hold themselves in place. The advantage of some of the balloon type ones, of course, is that they have a lock, and you line up the tab and you turn it. Now, I'll be honest, kids, you think, they're not developmentally up to where we are. You'd never let them drive a car, go on a date by themselves. But it's interesting how ingenious they are, or maybe just they work at something long enough and they'll figure it out. And they will. They'll get this lined up and get it out. I still remember the mom who came to clinic and said, yeah, I caught him one night. He's on nighttime drip feeds, and he'd unplugged himself and was painting the wall with the formula. So, yeah. So, now, of course, this is button too tight, Yeah, well, yeah. This is like I said. The pictures are what the pictures are. This kid's a little heavy, and you can tell this button's been in a long time because the flap is broken off, and it's also kind of got the light brown color that says it's been in there a while. But this one's too tight. If this is a child that needs the button for some reason, this one's too tight. When it starts to pucker in, it needs to be replaced. So this is how you change a dome button. If you don't know, here's how you do it. Now, this is the Corkins method. Not written up, not patented, not copyrighted, unless we copyrighted this presentation. All right, so number one, I'm going to tell you one of the secrets to this is these things, the tabs on the buttons are very small when you're trying to do this. Also, most of us wear gloves when we do this. Now, the old-fashioned gastroenterologists, we did a lot of things without gloves on, but most of us wear gloves for most things nowadays. So you get a pair of gloves on. If you put the obturator in, too, you start to get formula refluxing because you're going through the valve. And so what happens, of course, is it gets slippery. So I recommend taking a piece of gauze, lengthening it out, and putting that around the button so you can actually get a good grip on it, because you got to get good grip on this thing to get it out. All right. Then you get the obturator. You put it in. Now, the obturator has to go through the button, through the reflux valve, and hit the tip and stretch it out. Now, the Murphy's Law thing? There's the holes right here for the, to let the formula out. When you put the obturator in, it seems to find the hole. It always seems to find the hole. So what you do is you've got your gauze around the button, and you got a hold of it. You got a good grip on it. And you're putting the obturator in, and you're trying to be careful, and you feel. Of course, when you hit the tip, of course, there's a little divot in here, and it'll hit the tip, and then you meet resistance, so that you know you're in the right spot. Basically, then what you do is you basically put the obturator through, and it will stretch the button, basically stretch it out to where it can be removed. And what happens, it'll pull right through. Again, you don't want to do this when the button's mature. The literature varies a little bit, but most people would say at least 8 weeks after it's been placed before you'd even think about changing one. But then you can change it, and then most of the time what most people do would go to one of the balloon-type buttons at this point, again, one the parents or another caregiver or nurse could change. Feeding after you place a PEG, all right? How soon can you use it? Feeding after placement. Literature indicates anywhere immediately to several hours. The recommendation from 94 was 2 hours in adults and 6 hours in children. I have to admit, I was looking at some literature, and a thing came across my desk at one point that where a group in adults were feeding them post recovery. They were feeding them in recovery. They literally hooked them up after they placed their PEG, because if you're going to have a problem, you're going to have a problem anyway. You're creating a perforation when you do a PEG. So I thought, well, let's try that in kids. So I went to IRB, and IRB in Indiana at the time was rather conservative. And the other thing that happened is our recovery room really wasn't set up to do feedings. So what happened is we ended up doing our study at 3 hours. So basically, we published this in 2010, that basically we had no complications or increased rate of problems with kids when we did their gastrostomies and fed them 3 hours afterwards. That's about the time they hit our observation unit. So gastrostomy, do they need a fundoplication? This is a lot of controversy for a lot of people. the reflux potential seems to be pretty minimal, except kids with neurologically impaired issues. And those kids, the literature that's been done says if you have a neurologically impaired kid who had an abnormal pH probe prior to needing a gastrostomy replacement, you're probably going to have reflux and you probably need a fundoplication. The literature on PEG tubes in the majority of kids is actually they do pretty well. You don't necessarily have to do a fundoplication. A gastrostomy is not an indication that you need a fundoplication. Does that make sense? All right. Jejunal feeds, you can place a jejunal tube through a gastrostomy site. You have a kid, you put a button in, have issues, you can put a jejunal tube right through the gastrostomy and snake it into the small bowel. Sometimes your radiologist can do that. Sometimes you can pull that down with an endoscope. It's kind of fun to do. It's a little bit of a challenge. Although there is some literature that a direct jejunostomy requires a lot less intervention. In other words, you put a jejunal tube in and they always come out on Friday night, It's date night with your wife, you're at a nice quiet dinner, you got a babysitter, the music's soft, she's looking in your eyes, and the pager goes off, and the jejunal tube is out. All right. Tube clogging. Now, the best thing for tube clogging as far as using an enteral tube is don't let it happen. All right? Prevention. We're pediatricians. We believe in prevention. Flush it. Put a little warm water in there. Now, there's been lots of studies looking at lots of different things. Cranberry juice, Coca-Cola, a little red wine, That would be the Cincinnati approach. Yeah, no. A lot of red wine. And then you don't really care all that much. Anyway, all right. But flush after every bolus or after every 4 hours of continuous feedings, and the lowest volume necessary to clear the tube. In theory, you could get some, volume. You could fluid overload the kids if you give them too much fluid. Mechanical devices are sold and used in adults for when you develop a clog in your tube, but there's none for pediatric-sized tubes. It's called a tube zapper, and they have this mechanical device. Loss of substances, like I said, but the studies actually show that the best method to dissolve a clog is warm water. And what you do is you have warm water, you instill it and withdraw it. Warm water, instill, and withdraw. Basically, it's safe and it's low cost, and it seems to be in the studies the thing that works the best. Misconnections. This is a huge issue now, and there's been a national initiative to improve safety. There's been several reports of people who had enteral nutrition hooked up to IV lines, and several reports of that. 5 minutes. All right. So basically, these are some things that have come out as far as national guidelines to try to prevent this. Number one, train the family members and visitors not to reconnect the lines. Don't do it. If it's not connected, leave it alone. Let somebody, a trained medical professional who knows what's supposed to go where, look at it. Avoid modifying or adapting IV devices for enteral use. And there's a big initiative, and they're actually developing systems that are enteral specific versus parenteral specific. And they've had a lot of work and a lot of engineering going on with this. And they're trying to make it color coded so that it'll be separate. And that's still not totally in place, but they're working on it. But, I have seen all sorts of Christmas trees and adapters and tape and all sorts of things. And that's very dangerous. When you're reconnecting lines, trace it back to the origin on the body. Where's it going in, Because that's where you're going to get into trouble if it's going in the wrong place. Retrace all the lines to the origin when doing a handoff or a shift change. So every time somebody new comes on, you look at where it's going, trace it back to the origin. And basically, if we just followed these simple steps, we'd avoid a lot of these complications. Any questions? That's it.
Just a quick question about one-step versus two-step PEGs.
Yes.
We started trying to do one-step, and we noticed some complications. They gained, like we had one cancer patient gained a lot of weight within the first 8 weeks. They're on steroids. And you can't really take it out with an obturator. And then, so we had to take him back anyway and under anesthesia to remove it.
The key with that is literally placing one that has, I tell the parents, the gastrostomy I'm going to place initially, I'm going to have extra length in it. I do that on purpose because I actually like to leave that first one in as long as I can. And I tell them the first one's going to have these spacers under it. You have the rubber spacers or silicone spacers. And the first one I put one that's a little too long in on purpose. And they'll grow into it. And I tell the parents, bring that baggie. I gave them the baggie of the spacers, and they bring it back with them, and I go to thinner spacers as they grow. So the key there, and I've had one that got a gastrostomy, and it was a delayed kid, and the mom started giving the kid nutrition and grew like gangbusters, and it got too tight and caused some complications. And literally, always put one that it's too long. Leave yourself the lag there on your gastrostomy, or you're going to end up with that issue. I do find the acceptance with the one-step buttons is much better than the tubes. Parents prefer that. It's interesting. You meet a lot of resistance up front. I don't know about what you guys have seen. A lot of resistance up front with placing gastrostomies. And then after a couple of months, the families usually come back and said, why didn't we do this sooner? You're kind of like, because you wouldn't have listened to me. But it's amazing how often that happens. They come back to you and say, we should have done this sooner. This is so much easier. This is so much better.
Do you have preferred one step that you use often?
I've used several one steps, and there's no preferable one. It's just, I think in a way, it's what you're most comfortable with. I am one of those people. I am conservative, entrenched, right wing, type. Although I do not own a gun, but what's best is a system that you use, are comfortable with, and know how to use. I mean, literally, it's all of us, when you get out of your comfort zone, it takes a while. And so whatever you've learned to use, that's the one that's best for you.
Now, in your study, when you fed right after placing the peg?
Well, 3 hours.
Right, 3 hours. Are you using continuous feedings? And then
no, we did boluses. We did boluses. Yeah, we did boluses. I'm not trying to blow my own horn in a way, but what we found was interesting. We looked at abdominal diameter and some different things, and it seemed, again, it was a trend, but it seemed like the function was better the sooner we used it. We seem to have less problems actually with the kids if we used it a little sooner. And I always say it's use it or lose it. It seems like the ones where we had the kids, because we had a standard of waiting the 6 hours. So we did 3 versus 6 hours, and the kids who used it 3 hours seemed to do a little better than the 6 hours.
And how soon did you send your patient home?
Oh, now, unfortunately, that was still pretty entrenched, and they went home the next day. They stayed overnight, and most of that was basically because of teaching.